Thank you. So at this point, I'd like to invite all of our speakers to the table. Ali and I will move to the podium and we'll open it up for questions and discussion. You want to do the closing announcements? Okay. Okay.
Yeah. So we have microphones on either side for anyone who's got a question, and please point out who you're directing your questions to.
And maybe introduce yourself, please, as you start your question. Go ahead, please.
Yeah?
Yeah.
Yeah, Professor Truman, it's a very nice talk. Just a couple of points. Number one, was the after the temporary clipping, was systematically the papaverine was put? Were there any data to that? The papaverine application after the temporary clip, did you have the data that it was systematically applied every single time the blood pressure come up, and you take that precaution so that you don't have the spasm?
Yeah, I briefly mentioned that. Great question. And we don't, basically, right? So because it is not necessarily well captured in our operative notes. And since this is a retrospective study, it's a little bit difficult to go back and how many times did I put papaverine there? Did I put it there in the first place? Some of us do it every time, some of us don't. So I would say it's a little bit unclear what actually happened there.
So just to follow very quick, I see that your average diameter of the aneurysm was 5 millimeter. So you treated, and majority of our unruptured aneurysms.
Yeah.
So has the indications changed? I mean, we don't treat a 3 millimeter aneurysm today, unruptured aneurysm, we just follow up. Is that is changing in North America? What's your standard of treatment? Indications of unruptured aneurysm, 3 millimeter ophthalmic segment aneurysm.
Yeah, so great question. So it's not a if you will, equal or symmetric distribution, right? So the pretty much the majority of these were between 4 and 5 millimeters, and then you have a longer tail towards the larger sizes. Of course, there is no very few aneurysms only that were much smaller than that. And those are typically patients that either had a rupture or have.
Well, you had the largest number, was only very few cases of rupture.
Yes,
most
right.
are unruptured aneurysm.
Or had another aneurysm that was ruptured, and we looked at that second aneurysm and said, we think that is, maybe higher risk, and we're going to be more aggressive with that one.
I just want to have the house, we just advise, because we don't advise our patients to get treated based on the evidence we have. Has it changed? You people treat on 3-4 millimeter ophthalmic, 4 millimeter is below our indication of treatment as of now for an unruptured aneurysm. Has it changed? You people treat it in North America? What's it like? Can you advise? Any of
where you are? Depends. The reason depends where you are.
So is that evidence to treat these patients?
I don't think so.
Okay, thank you.
I think what I would say is that obviously size is one feature, morphology, multiplicity.
Can you speak a little louder? I can't hear you.
Sure. Yeah. So size is one feature, morphology, multiplicity, personal history, age of the patient, all of those things, I think, are things that we all.
So why I'm asking, most endovascular colleagues are treating this, whereas most microsurgical colleagues, at least in my country, we would not treat it. The moment the patient has an aneurysm, for whatever reason, head injury, 3 millimeter, 4 millimeter, come for endovascular treatment. So it's
I wouldn't say, and I'd hope, I think, given the experience in the room, in no one's practice is there an absolute dogma that you treat all the aneurysms. I think the spirit of your question is, are there certain 3 millimeter aneurysms that merit treatment? In my view, the answer is yes. Does that mean we treat every 3 millimeter aneurysm? Probably not.
I concur. On an individual basis, based on multiple different factors, you may choose to treat a 3 millimeter aneurysm, but as a general rule, they tend not to be treated.
Other questions for our speakers? Yep, please.
Continue the discussion regarding the risk of vasospasm or at least ischemia applying temporary clips. Do you perform any measurement to avoid thrombosis? particularly if you are clipping for a longer period? I'm asking that because in our department, if you are planning to clip for more than 3 minutes, we used to apply 3,000 units of heparin during surgery. We can even neutralize these later on if it's necessary. So is these a usual measurement? Are you performing that? Is anybody doing similar?
Yeah, so I think that's a great point, and in hindsight, right? So I can say we pretty much never do that. That would be an aberration. I think looking at this data, what do you do next, right? How do you learn from it? I think that's a very interesting question, right? Does that help to negate this problem, especially for cases where it was longer clipping periods? So I think that's up for discussions. I'd love to hear others weigh in on this.
And the question is whether these might be thrombosis instead of pure vasospasm in those cases.
Clemens, did you change your practice? I mean, in Germany, and I think most European centers, we use nimodipine during irrigation of cerebrovascular, but also skull-based procedures to prevent vasospasm. I increased blood pressure during temporary clipping in addition to that. So did you change anything? And is there, I think nimodipine is being considered for FDA approval of IV in the US, right? It only existed, I think, orally.
Yeah, currently this only exists orally, and is of course something that the ruptured group would have as a medication, because they're in the hospital for this subarachnoid. But the elective group would not be on nimodipine, of course. And intraoperatively, we just keep it relatively simple. So we only would use piperacillin if you see something, right, in a topical application afterwards, but not necessarily preventatively, I guess. And then also, we do raise the blood pressure. We do, specifically hydrate these patients, and we basically try to put them in the best physiological position to avoid vasospasm, but we don't actually do anything specifically for vasospasm, right? This is more meant to essentially put the patient in a position to recruit collaterals and don't have any sequelae from that temporary clipping period.
I'm just mentioning this because, I mean, even in this sort of 20 years ago, Steiger introduced this. And I think what we see, like the heat that is generated through the microscope, is an additional risk factor, right? The blood vessels kind of dry out. So if you continuously irrigate with a low dose nimodipine, it may be helpful if it exists in the US.
Yeah, Garni.
Thank you, great panel. I have a question for Dr. Thompson. It was interesting to point out that local blister you had seen on the carotid, and I'm sure you've operated on other patients who've had prior stenting and coiling. Have you seen any other types of changes to the vessel wall, and how do you approach like a previously stented vessel when going back in?
That's a great question. I worried about it a lot. The reason I showed that case is because, we've all seen that. That's the first time in dissecting it. I only took the sucker off it for a second, but it was bleeding. And that's the first time I've seen it, but it made me wonder. I couldn't answer that in a systematic way, Garni. I wonder if it's the case, but I don't know for sure. That was the only time I've seen that.
Yeah, congratulations to the speakers. One comment and one question. I think, Basant, to your question, something that the speakers didn't mention was the small aneurysm that we observe for a year that comes back a year later with growth becomes a subset of patients that feeds that treatment aggressive posture in patients that still have that small-sized aneurysm under the 7 millimeters. So we see that frequently. And then a question for Spiros. I loved your talk, and I think this idea of defining eloquence, particularly as it relates to AVM resection, is really interesting, and the TMS is a great way to do that. I'm curious what your protocol is in mapping eloquence in your practice, both with AVMs and do you do that for all of them? And secondarily, what can you map beyond just the standard somatotopic systems? Can you map other networks or higher cognitive function?
Thank you so much for the question. So far, we did this mapping during my fellowship in Toronto Western Hospital, so it was about a year. And we incorporated for all the Elecon AVMs, like speech, in the visual cortex, somatosensory, and motor. So higher cognitive function is a great question. I think this is where the next step could be, should be. So it's possible to, of course, map very well the AVMs in the motor cortex, AVMs in the visual cortex, as I saw with retinotopic mapping. But the higher cognitive function, we don't have I have not come up with a protocol yet, but I think this is where the next step will be to provide better outcomes for patients who have lesions, not in, as you said, not in motor and vision, but where the cognitive function is. So yes, that's a great idea.
Can I just make a comment about this blister aneurysm? We have seen it pre or without endovascular, previous endovascular. I just have one comment. You put a clip. I mean, you would be very, very scared to just directly put a clip on the on a blister like that. You know, we would put a construct. Do you do that, or I mean, we would put some cotton or some muscle over it because these are really they just rupture and blisters are dangerous. We have a series for whatever reason I have, but we always were very careful. Have temporary clip, put muscle, cotton, and then over that we put the clip. But I saw that you put the clip directly on that.
Yeah, that's a great question. I've seen a lot of dorsal wall aneurysms. This was a particularly small one. It's the first one I saw that small in the context of previous endovascular treatment rupture. But it was so small, honestly, compared to the vessel, I didn't feel compromised at all in putting a small, you could see it really didn't have much difference, make much difference on the diameter of the vessel. So I checked it, as you could, maybe it didn't show up in the video, but took the temporary clips off, did ICG angiography and watched it a little while. But I think it was very stable.
Other questions?
Dr. Samuel?
First of all, my congratulations for all the speakers. Really, I enjoyed it so much. But we have such an expert with us about aneurysm and clipping or interventional. There are, you can imagine, as I started, we had no interventional possibilities and we had to clip an aneurysm. I have done really more than 1,000 clipping of aneurysm, any location with every problems that you have described here. But there are at the moment two questions. One question is, what do you think is the percentage of microsurgical clipping or treatment and the interventional? Is that from department to department different? Or there is at the moment a general rule which one should be treated by interventional, which one should treated by clipping? And the second question would be, how many percentage you believe, because I have operated many cases after interventional technique and they ruptured or they were partial and the patient was in trouble and I had to operate and then clip and take also the things out and blood out. And what is the percentage? Have you an idea? Can you give us some information about the different department or generally what is the rules that you said? This is interventional, this is the, I know, I can only make your job easier. Middle cerebral artery in the trip provocation, that we all know that this is almost a clipping case because it's difficult for them. But what about the all others? Please.
Yeah, I mean, I have a perspective, but I want to invite our speakers first. Anyone want to address Dr. Sammy's question?
Yeah, sure. Is this thing on?
No, that was not on.
It's on.
Yeah.
That's a great question. I think it's evolving in my own hands, in my own practice. The patient comes to me. In the past, I would have to work with someone. Now they come to me. And I make a decision based on the anatomy, what I have in my own hands, the patient's moment, what do they need? So for paraclinoids, I say now, the majority of the aneurysms is I treat endovascularly, 80%. For PCOMs, so older patient, they're going to get coiled. Younger patient, clipped. MCAs all get clipped, but what I see more often now, even double stent, Y stent coils, and then the patient comes with a growing aneurysm. Now you have a harder problem to deal with. And as the question was pointed out, these are 3 or 4 or 5 millimeter MC aneurysms that we wouldn't treat, but someone has treated. And I take it broader than that. Microsurgery and cerebrovascular is great for AVMs. I think that's really where it is. Bypass is the right thing for moya moya. There's not a real endovascular solution for moya moya. Stroke is an endovascular treatment. We aren't doing open thrombectomies. We don't need to do it. So ischemic stroke should be in the hands of neurosurgeons who are doing all of cerebral vascular. Carotid disease is best done with endarterectomies, but when you can't or you need to do something else, you put a stent. It isn't about opening a book and getting an answer. It's about what you have in your moment, in your hands, and how then we follow the patients and make sure that I try to do better year to year.
Any other comments on Dr. Sami's question? And then I want
I would just say, I think there's no general rules. I think you need to look at the specifics of the patient, and I think that drives most of the decision making, actually. And then you got to look at the decision on what's the best or most effective treatment of that particular aneurysm that you're looking at. Because in my mind, the most straightforward or most simple solution is usually the most effective one, which comes with the least amount of complications for that patient. So in other words, I don't think there's any general rules or any target distribution that we're after.
I have a critical question.
Yeah.
Because in every department, from one side, we have a very active neurosurgeon ready for clipping. On the other side, we have an interventionalist to take the catheter. But please be honest. I had really pleasure to have the best interventionalist almost in the world, Balavanis, you know him. He was a master, but I learned from him how difficult is, how complex is the interventional treatment. Not every interventionalist is as good as the neurosurgeon who has really learned how to clip the aneurysm. They can make more problems and complications if it is a very weak interventionalist with a great neurosurgeon on the side. Is that true or not?
Yes.
In every department, we have highest level of interventionalists to be able to treat all aneurysm with interventional? No. It is, of course, some very afraid neurosurgeon for clipping. He is happy to send it to the interventionalist. I don't want to operate. Please be honest and tell me this situation. How is in your department?
Yeah, do you want to go ahead and then I'll make a comment?
So in our part of the world, I think it's 2 things which decide where's the patient going to land up. The first consultation where the patient gets it and whether he sticks to that consultation or not. And the second thing, whether it's a publicly funded hospital or a privately funded hospital, and whether the patient is insured or not. This is the blank truth setup. Yeah.
So I'm a neurosurgeon doing both the procedures. Presently, as your questions, answer to their questions, 70% of my practice I am doing a microsurgery. Symptomatic cavernous carotid aneurysm, no doubt about the endovascular treatment, and that is a US FDA approval. MC aneurysm, straightforward clipping. Even a PCOM aneurysm, I go for a clipping. That is my first choice. I always discuss with the patient because many times we talk in the literature, discuss in the scientific meeting, but we don't take an opinion from the patient, like what patients wants. And many times you will not believe, sir, I have lost 3 patients waiting for endovascular treatment, arranging the money in my unit because they are reluctant for a microneurosurgical treatment. So it is very much common, like it's a demand from the patient family, and many of the neurosurgeons who are doing intervention, they are adjusting themselves, not actually the scientific, like a scientific criteria, what we discuss in the meeting. We always respect the decision of because they don't know what will happen over a period of 5 years, 7 years down the line. So sir has nicely shown a case, 9th day post-operative. There was a massive subarachnoid hemorrhage and patient, he lost the patient following and in my clinical practice, I have seen a couple of cases, a patient doing absolutely well, following a fluid aortic replacement, maybe over a period of 5 days, 7 days, suddenly loss of life. So that is happening.
And what is the economical issue? For example, in India, it's cheaper to clip aneurysm?
Yeah, in India, it's a very cheap to clip an aneurysm. Again, like it depends, you are in a private setup or in the government setup.
The governmental.
Yeah, government setup, it's sometimes very difficult to arrange about the funds.
Clipping is cheaper.
Yeah, clipping is cheaper.
Yeah, and so.
Yeah.
Dr. Sani, I think the spirit of your question is less the decision rules around a particular type of aneurysm, but more the absolute distribution. And I think that distribution varies depending on how many ruptured versus unruptured aneurysms a center treats. Because I think those distributions are different. And so when you think about an elective unruptured practice, I think in general terms across most US centers, that number is going to be in the 70 to 80% endovascular and the 20 to 30% open surgery. For ruptured aneurysms, the thing that really defines if an endovascular center is very aggressive is their philosophy around dual antiplatelet therapy and integralin for the use of adjuncts in the rupture setting. Because most of the complications that we've encountered with the rheology or pharmacology are less with re-rupture or thrombotic complications and more with the results of issues with flow diversion, CSF diversion in patients who actually are ion antiplatelet agents. So the abuse that I see of endovascular in North America now is someone who comes in with a ruptured aneurysm that would have a good microsurgical solution. That person gets committed to dual antiplatelet therapy, maybe gets a well-intended flow diverter or stent-assisted coiling. Those are situations where I think the pendulum in intervention has swung a little bit far, and there's a missed opportunity for the definitive application of microsurgery in those situations. So in my practice, for ruptured aneurysms, I think it's probably closer to a 65-35, meaning still favoring endovascular, but being a little bit more aggressive with microsurgery. Because I don't believe in dual antiplatelet therapy quite yet in the rupture setting unless absolutely necessary.
Very variable, extremely variable. You have many extremes.
Yes, it's 10 o'clock on the dot. Do you have any closing announcements before the break, Shaq?
Okay, some announcements. We can keep going on forever. I love this session, but thank you both for co-moderating this and the speakers. Some announcements, the breaks. Yes, there you go.